thank you to Dr. Beale for presenting to us tonight and again tomorrow and taking the time out of his very busy schedule. I understand that he literally just finished in surgery to do this, so really appreciate that. I think Dr. Beale is likely a name that's familiar to many of you already, but just as kind of a quick and brief background, Dr. Beale became board certified by the American College of Veterinary Surgeons in 1991, joined the Gulf Coast Veterinary Specialists the following year, and he's had a special interest in arthroscopy, minimally invasive surgery, fracture repair, joint replacement, treatment of arthritis, and pain management. He's the past president of the Veterinary Orthopedic Society and became an ACVS founding fellow of minimally invasive orthopedic surgery in 2018. Dr. Beale is currently the CEO of Beale's Best and Beale Veterinary Specialists in Victoria, Texas. And I really appreciate that he's taking time out of what is obviously a very busy schedule to join us tonight. And with that, I will turn things over to you, Dr. Beale, but we'll obviously be online if anybody needs help.
Okay, well, thank you very much, Heather. I'm going to go ahead and switch over and see if I can get my presentation up here. Let's see where it went. There we go. Okay, can everybody see this okay? Can you see that, Heather?
Yep, it looks great. Perfect.
Okay.
Thank you.
Awesome. Well, thank you for having me. I certainly wish I was up in Canada doing this. And, you know, it's just another one of those webinars. So I'll try to keep this interesting. And again, if you have questions at the end, I'm happy to take those. I'm going to talk about something that I see every day. And it's something that I think is very, very important for our pet owners and for our pets, because one of the things that we see most commonly as far as a hind limb lameness is a torn cranial cruciate ligament. And they're not always obvious. So what I hope to do is give you some tips that will help you diagnose these early. We know that if we make an early diagnosis and treat it at that stage, the animals are going to do a lot better long term. So first, I want to just mention to you something that we're doing now in Park City. We have developed our own continuing education center. As many of you know, I've taught at the Las Vegas facility, Viticus and Oquendo Center for about 10 years, and also at Colorado State at the TMI Institute. And we basically did the vast majority of all the orthopedic courses there the past 7 to 8 years. Now we've changed up things. We wanted to do something a little differently, and we've built our own education center in Park City. And the instructors and faculty that we had with me at the Las Vegas and Colorado courses have come and joined us. So what we have is a hands-on continuing education center, but the big difference is that it's actually connected to a specialty hospital. So what we can do is not only train in the lecture and the laboratory setting, but also we can bring people in and actually see the procedures that we're doing in the clinical setting as well. So the instructors that you're only going to find now at our facility in Park City are Dr. Hudson, David Dykes, and Dr. Jones from Ohio State. So we've been able to keep our faculty together, and we're offering a multitude of different hands-on courses using cadavers and plastic bones in our Park City location. But we actually have 3 other locations coming soon in Baltimore, Maryland, Fort Lauderdale, Florida, and then also Houston, Texas. So I hope I've taught many of the Canadian veterinarians, especially in Las Vegas. We're hoping to get you to come over to Park City and try that out instead of the bright lights of Las Vegas. This is the Park City town. It's an old mining town, just very, very quaint, a lot of fun, great restaurants, just a pleasure to join, and it's right in the mountains, and it's only a 30-minute drive from Salt Lake City. These are the type of views you're going to see in Park City, just these beautiful mountain views, fantastic powder skiing. It's got the best snow in the US. Beautiful sunsets, just very peaceful. Lots of heavy, deep snow in the winter, but in the summer, it's just as beautiful, and a lot of summer activities and a lot of summer sports as well. Beautiful sunsets, as I described before. Lots of wildlife to see. And if you like golf, we have a ton of amazing golf courses here, and your golf ball flies very far. It's great family fun, you know, in the summertime, bring the family along, great fishing, great skiing, great inner tubing, and fantastic food. And it's just a place to relax and have fun. So I hope you'll join us here in Park City, pass the word around and tell people to come here instead of Vegas. So if you want to see our courses, you can go to bealesbestce.com. We basically have 1 to 2 courses a week starting in 2022, but we actually have some still in 2021 if you're trying to get those CE credits fulfilled. Okay, so enough of my little advertisement there, but I just wanted to make everybody aware of that because I love working with everybody on a one-to-one basis. We're going to talk about cruciate injury, and it's important to realize that cruciate injury certainly leads to lameness, but more importantly, it leads to osteoarthritis. And as you well know, once you get osteoarthritis, you've got it for life. So we're going to talk just a little bit about why cruciate disease occurs and how it occurs. And we're going to kind of differentiate a little bit between partial tears and complete tears, because probably at least half the tears that I see are partial tears. And this is the perfect time to catch them and treat them. We're going to talk a little bit about meniscal injury because we see that in about half the dogs with complete cruciate tear. And lastly, we're going to focus a little bit on the long-term management, because a lot of people think, well, I fixed the cruciate, now I don't have to worry about it. But that's really not true, and I'll show you why in this talk. So as far as anatomy goes, you know, radiographic anatomy, we can see joint capsule as pointed out here, both not only cranially, but also caudally. And so we're looking for swelling of the joint capsule. We can tell that by disappearance of the fat pad when we're looking at the cranial aspect of the joint. But caudally, don't forget to look back here too. So when the joint swells, we'll tend to see swelling caudally as well. So it's just a way that you can reassure yourself that there is some change in that joint. So the normal cruciate runs in this direction here. So this is the cranial cruciate. It actually originates very caudal and runs across the joint and inserts on the cranial aspect of the tibial plateau. And the job of this cranial cruciate is to keep this tibia aligned underneath the femoral condyles. If this cruciate tears, the tibia starts to creep cranially, and it doesn't align or articulate properly with the femoral condyle. When we look on the AP view or the cranial caudal view, you can see that the cruciate actually originates on the lateral side of that femoral condyle and crosses the joint and inserts on the medial side of the tibia. So this is important to realize that the ligament is crisscrossing across the joint. The other thing we want to make you aware of is the top of the tibia is not horizontal. It's actually at an angle, and this is called the tibial plateau angle. So you can see that this angle is going to play an important role in why the cruciate starts to tear. This angle varies greatly from individual to individual, and it also varies depending on the size of the dog and also the breed of the dog. So I'm going to teach you how to measure that angle, because this is one of the prime reasons why an extracapsular suture may fail. So you need to know how to measure that angle and know when it's excessive that could lead to this failing. So the cruciate ligaments are paired ligaments. We were just talking about the cranial cruciate ligament, but there's also a caudal cruciate ligament. And this is what it looks like if you look at this image on my screen. So the cranial cruciate ligament you can see is kind of twisting because it actually is made up of 2 parts, and we'll talk about this. But the cranial cruciate comes cranial, and you can see the caudal cruciate is going caudal. So the cranial cruciate is made up of a lot of collagen fibers, And surrounding that is the synovial lining. So let's take another close look at this. So you're taking a look at the cranial cruciate ligament here, and you can see that it's arising from the lateral femoral condyle. So this structure right here, this tendon right here, is the long digital extensor tendon, which originates from the lateral condyle. So the cranial cruciate also originates very caudal in this inner condyloid area or intercondyloid notch. So again, this is the caudal cruciate. This is the cranial cruciate. Now, if you look very carefully, you can see that this cranial cruciate has two bands. Okay, there's one right here and one here. I'm going to go ahead and highlight the one that's behind this one. This is the cranial medial band in blue. This is the band that typically tears in a partial tear. Okay, the one in front is actually the caudolateral band. And again, it's kind of a crazy thing. I just said it's in front of the craniomedial band, but it actually is called the caudolateral band because the origin of this band actually originates more caudal. But as it courses across the joint, it comes cranial to the craniomedial band. And this caudolateral band is actually larger than the craniomedial band. So the blue band, the craniomedial band, is the one that tears most commonly in a partial tear. But it may be difficult to see with your naked eye because you might see fibers that look perfectly normal coursing over top of it. So I'll show you some examples of what to look for when you're doing surgery to help you diagnose a partial tear, because I don't want you to go into surgery, see intact fibers and say, oh, I made an incorrect diagnosis. I was wrong. It must have been that hip OA that was causing a problem. No, in fact, it is the cruciate. You just need to know where to look. Also, the meniscus. You need to learn how to see the meniscus, and that's very hard. I know I sometimes have difficulty, and I'm sure a lot of you have too. So when I teach people how to treat cruciate disease, I also teach them how to identify meniscal tears and how to treat those meniscal tears. And I'm going to talk about that briefly in this lecture. So we can see the cranial cruciate here is inserting medially at the front of the tibial plateau. Okay, we can see that here. And it inserts actually right near the medial meniscus. So here's the medial meniscus, and the medial meniscus is the one that typically tears. Okay, the medial meniscus is attached to the tibia by a little ligament cranially called the meniscotibial ligament, so right here. And it also attaches caudally by the caudomeniscotibial ligament. So you can see there's a ligament a cranial and a ligament caudal. The reason I point these out is a lot of you will, when you have a torn cruciate ligament, you'll remove the torn fibers here. You have to be very careful. If you cut this ligament off the bone, you can accidentally cut this meniscotibial ligament, causing the meniscus to become unstable. So when you're removing the torn cranial cruciate fibers, make sure you just leave a little bit of the torn fibers on the bone. Don't try to scrape it off the bone, or you may actually damage the medial meniscus. Okay, so these are two ligaments that attach to that medial meniscus. So this yellow area here, or this little blue area here, if you cut too close, you may damage those. So go ahead and leave a few of these torn fibers in place so you keep those ligaments of the meniscus intact. Okay, so we're going to start talking about what we do to diagnose and treat these ligament tears. So basically, the cranial cruciate ligament can rupture, and there's three types of tears. There's a traumatic tear. Traumatic tears are the most common tear in us. So when men and women, mainly athletes, tear their ACL, most commonly it's a traumatic tear. So in other words, their cruciate is perfectly fine 1 minute and it's torn the next minute, and it's usually a complete tear. The most common tear in dogs is a degenerative tear, a tear where the ligament starts to degenerate and tears gradually. Lastly, in puppies, there's something called an avulsion tear, where the ligament is intact, but a piece of the bone tears off or breaks off of the femoral condyle, and the ligament, you get ligament instability only because it pulled off a piece of bone with it. So in those cases, you can actually reattach the bone, and that'll fix the cruciate. So again, the middle tear here, the progressive degeneration, is by far the most common type of tear in the dog and in the cat, actually. So degenerative cruciate tears, we're going to spend a little bit of time on. So this is a progressive degeneration of those collagen fibers. Now, in the very early stages of that, we call that an early partial tear. And if you check cranial drawer in those cases, you're going to feel a normal stability in the knee. So it's going to feel like a normal knee. But these patients have an intermittent lameness, and they're actually starting to get OA even in this early stage. Now, as time goes on, and it doesn't have to be a long period of time, a month later, 2 months later, the knee starts to become more unstable. And so when you palpate cranial drawer, then you're starting to get cranial drawer. So these dogs here are just a later stage of the same problem. So the more collagen fibers have torn, the dog's going to be a little bit more lame and a little bit more unstable. If you give a little bit more time, many of these dogs will go on to a complete tear. So we have two types of partial tears. We have an early tear where the knee is still stable, and we have a late tear where the knee is unstable. Now, we treat all three of these. We don't say, because it's an early tear, we're going to see what happens. These dogs will continue to tear. And the earlier you diagnose it and earlier you intervene, the better your result is going to be. So you don't want to tell your clients, oh, we're just going to see what happens. You want to make the recommendation at that point in time. So just to summarize, here's man. And you can see that this is how we generally tear our cruciates. We either have hyperextension of the knee, as this rugby player is getting tackled and hyperextended the knee, or we plant our foot and we twist the knee, but the foot doesn't twist with it. Too much internal rotation. So in this case here, this guy's cruciate was like this right before that tackle, and now it ends up like this instantaneously due to acute trauma, a complete tear. This is the classic tear in human beings. Dogs, the cruciate ligament looks very similar to the human knee. And when it ultimately tears and goes to a complete tear, it also looks very similar. But it's the mechanism, how you get from point A to point C, how this occurs. It's chronic repetitive trauma that causes this degeneration. So it's not that acute traumatic episode that we see in this rugby player. What happens is we get chronic stresses that induce biological changes within the joint, and this weakens the collagen fibers and causes it to go through an intermediate stage where we get some fibers tearing and other fibers intact. With continued chronic stress and more biological changes, you have this inflammatory situation in the joint, and eventually many of these partial tears will go to a complete tear. So the pathogenesis involves multiple factors. There's certain mechanical factors that stress the ligament, causing it to tear. We already mentioned one. If the slope of the top of the tibia, that tibial plateau angle, is high, then that puts a lot of stress on this ligament, causing early tearing of these fibers. So this is a cranial medial band tear here that I mentioned before. You'll notice the caudolateral band looks perfectly normal. The cranial medial band is one that tends to start to tear first. So when you're looking at the ligament, you want to look very carefully at the insertion point, very medial because this is where you're going to see the first fibers that start to tear. Now, there's other mechanical factors that can stress out this ligament. If the dog has a very upright stance, like a Rottweiler, puts more force on the ligament, and that can contribute to it tearing fibers. If the dog's obese, another factor. And if this notch where these ligaments live is very, very narrow, it can also put added stress on this ligament. Now, none of these individually have been proven to be the cause of cruciate rupture, but it's a combination, it's multifactorial. And these are all mechanical factors. No one's really focused on the biological factors, but we certainly know when we look in the joint, it's very inflamed. And the enzymes within that joint, the inflammatory enzymes and degradative enzymes are very high. So we know that there's a huge biological factor, and probably it's equally important, or maybe even more important than these mechanical factors. So there's a lot we still have to learn and identify with the pathogenesis of cruciate disease in the dog and the cat. So partial tears and complete tears, what I'm saying is it's the same disease, but it's two stages of the disease. And actually, it's a sliding stage of the disease because we have early partial tears, late partial tears, and complete tears. Without intervention, it's going to get worse. So you don't treat partial tears really any differently from a complete tear. So the types of tears, if you're actually looking at them, these are all arthroscopic images. I scope all of my joints. I do minimally invasive surgery. So a complete tear is completely torn. Here's that early partial tear where you can see a lot of the ligaments still intact and functioning, but there's an early partial tear. Now, these dogs still have pain. These early partial tears can still get arthritis. That's why we treat them here. Here's a later partial tear here, where you can see, this remaining part of the ligament does not look as tight or taut as it normally would. It looks like it's stretched a little bit. And then right here, you can see that the fibers that tore earlier are starting to round off. They're starting to resorb. So this is a late partial tear, and it's unstable. It's not good. When you test for cranial drawer, this is going to have cranial drawer here. Whereas this early partial tear, it's not going to have cranial drawer. Now, let's say occasionally you'll get in there and everything looks, you can't see any torn fibers. So this case here is a dog that had cranial drawer, but when we looked in there, we can't see any fibers that are torn. And the reason is the fibers that are torn are actually in the middle of the ligament. Remember earlier, I said that the ligament is surrounded by synovial fluid or synovial membrane. So in the case where you have these core lesions, the synovial membrane may look inflamed and may look thickened. And so you can't see any of the torn fibers inside. But we know they are torn in there because there's cranial drawer. Now I want to show you something that can happen. So if you look in figure A, so all these images are from the same dog. Let's look in figure A. And classically, cruciate disease is defined as a degenerative disease, okay? But that's really not completely true. It's a combination of degeneration and inflammation. So you need to think that this is an inflammatory disease as well. So in this sort of situation here, you can see that there's no evidence of swelling of the joint capsule. The joint capsule is not distended. It looks normal. There's no OA, no osteophytes. The joint capsule looks normal. Now, this dog's other knee actually has a complete tear. So we are actually fixing the dog's other knee with a TPLO, but we stuck the scope into the good knee because when we examined that knee, the dog still did show a little bit of pain. And when we placed the scope in this joint, here is the arthroscopic view. You can see that the joint capsule, which is normally flat, has a lot of hyperplasia, and there's a few torn fibers of the cranial cruciate ligament here. So this normal knee actually has synovitis and a very early tear of the cruciate ligament, but radiographically, it looks completely normal. Now, that dog had a TPLO and then rechecked 2 months later and had actually started limping on the opposite knee again. So again, look up at A. This is the opposite knee at the time of the original TPLO, and look at D. This is 2 months later after fixing the opposite knee. And now you can see within 2 months, this partial tear has progressed. And you can see swelling in the joint now. The joint capsules distended both cranially and caudally. And in addition, you can see right here where I'm outlining with my arrow, you can see osteophytes starting to form. So if we go up to A, there's no osteophytes here. But within 2 months, we already see osteophytes forming, swelling in the joint, and the tibia is actually starting to shift cranially. If we stick the scope into this joint, you can see that the synovitis has increased. So this synovitis is actually the source of this arthritis. So I want you to keep that in mind. So this is a great learning case here. So here are joints looking arthroscopically. These dogs all have partial tears, but there's osteoarthritis in all of these dogs' knees. So again, just because you have a partial tear does not mean that the remaining ligament is going to protect that knee from OA. In fact, we know that they are going to get OA. I just showed you 2 examples of that in the slide before and this slide here. So if you diagnose a partial tear, the time to act is then. And there's a lot of advantages to doing that. So your history is typically going to be a dog that has persistent or intermittent lameness, and typically it's exacerbated by exercise. With time, you're going to start to see muscle atrophy, and these dogs will usually respond to rest and some sort of anti-inflammatory. But that doesn't mean they're getting better. You're just treating the symptoms. These dogs, if it's a partial tear or a complete tear, will tend to not sit normally like this chocolate lab. They'll sit more like this German Shepherd, where they put the leg out slightly to the side, and they won't flex up the hock tightly like this Labrador is. So this is called a positive sit test. This sit test is usually abnormal in both partial and complete tears. So if you have a history of a dog that has an intermittent lameness, the owner brings the dog into you, and they say, sometimes the dog's fine, sometimes he's limping a little bit. If the dog's sitting like this, it's a cruciate tear until proven otherwise. Now, another feature that we see with complete tears or partial tears is if you cup the kneecap and you hyperextend the knee, they tend to show pain. So again, if you have a dog that's showing lameness, but on cranial drawer it feels stable, watch him sit and hyperextend his knee. If he sits with the leg off to the side or he has hyperextensional knee pain, you need to radiograph that knee. Now, a cranial drawer test is done. You want to try to get your thumb and your finger on the bone and not squeeze muscle in between. So this thumb is on the lateral fibula and the forefinger is on the patella. Now down here, we're putting our thumb again on a bony landmark. This is the fibular head. And over here is the tibial tuberosity where the patellar ligament inserts. So now what we're going to do is this hand is going to hold the knee steady, and this hand is going to slide the tibia forward. Okay? You don't have to put a lot of force. If you grab those bony landmarks, it's a gentle movement. Okay? If you're grabbing with your hands like this, it's very hard to move it. So that's why you want to pinpoint your fingers on those bony landmarks when you're doing your test. Now the hamstring muscles, those are these muscles right here, caudal to the thigh. they try to resist this movement. So sometimes if you're having difficulty doing this in the awake dog, you simply have to sedate the dog so that those muscles relax and you can get the movement that I showed you here. Okay. Now, another test that tests the same thing to show instability in the stifle is the cranial tibial thrust movement. And this is a test where we're going to basically flex the hock. And what we're looking for is the tibia, we're going to flex the hock. And what we're looking for is the tibia to shift forward. So we're not grabbing the knee and doing a cranial drawer test. We're actually cupping the knee and then we're flexing the hock. And if the cruciate is not stable, the tibia will move forward in that direction. So let's watch it on this specimen here. So this is a dog that has a cruciate tear. This patient is anesthetized and he's going in for surgery. So you can see we've cupped the stifle here and our forefinger is on the tibial tuberosity. We're going to look for this finger to shift in this direction as we flex the hock. Now, the reason this test works is because the top of the tibial plateau is angled and it's being pushed against a round femoral condyle. So when you flex the hock, it does this. Okay, so let's just watch this demonstration here. So as we flex the hock, watch the index finger move cranial. Okay, so that's a positive tibial compression test. And again, you can do this in an awake dog. It's not as uncomfortable for the dog compared to the cranial drawer test. So usually in the awake dog, we'll do this test, and then the sedated dog will do the cranial drawer test. Okay, you'll notice when we're doing this test that we're keeping the knee and the hock at approximately 90 degrees. Okay, we want to try to keep those a little flexed. Let's talk a minute about radiographs. So when we look at the knee, I want you to get a lateral view, and I want the knee to be in this position here. So what is that position? Okay, that is at 90 degrees flexion of the hock and the stifle. So I don't want you to extend the knee. If you put the knee in flexion like this, if the tibia is going to slide forward, this is the view that it will slide forward. If you extend the knee, the tibia slides back. So we're trying to document that the tibia is displaced cranially. And the way you do that is you flex the knee and you flex the hock when taking this lateral view. That's very, very important. It will help you make an early diagnosis. Now, we're going to measure in a minute the displacement and the tibial plateau angle. But first, let's just look for OA. And we can see this is a normal dog. And on the right, this is a dog that has a cruciate tear. And you can see here, the osteophytes right here. This is the first place to look. Right here on this femoral condyle, this is where the joint capsule attaches in the first place that gets osteophytes. We can see additional osteophytes oftentimes on the distal part of the patella. And then we can also see them in this region here where the cruciate ligament attaches. We'll see osteophytes in this location here. Again, you can also see very obvious swelling caudally and cranial of the joint capsule compared to the normal side. And you can see that the fat pad is getting smaller as that joint capsule starts to distend. Now what we're going to do is we're going to actually measure tibial translation. So remember when we were doing the cranial drawer test? Sometimes it's hard to feel that. But if you position the knee in this position here, you can actually measure that on a radiograph. Now again, if the knee's not at 90 degrees, it's not going to work because the 90-degree view is actually a stress view that pushes the tibia forward if the cruciate is not functional. So what we're going to do is we're going to look at the top of the tibia here. And you see, if you look very carefully, there's a little bump here. Okay. So what we're going to do is this is the center of the tibia. This is it's called the tibial eminence. And what we're going to do is we're going to take the very peak of that, and we're going to use that as a landmark. We're going to come down here to the hock, and you can see there's a circular structure here, which is the talus. And I want you to make a dot in the center of the talus. And we're going to connect those two landmarks. And this green line is called the tibial mechanical axis. So essentially, you're going from the center of the stifle joint to the center of the hock. Now, why would we want to do that? Well, this is the center of the tibia where all the forces run through the bone. Now, to measure whether that tibia is actually shifting forward, we're going to draw a parallel line to that green line. And we're going to draw that through the femoral condyle. So we're going to pretend this femoral condyle is a circle, and we're going to pick the center point, and we're going to draw a line right through that point that's parallel to this green line. So it's very simple to do this. And if anybody wants these slides, I'll be happy to send them to you. Just send me an email. My email address is brianbeale@me.com. And I will send you these slides, and you can have these as reference, and you can show your owners these. If you're in the exam room, you can pull up these slides and say, this is what I'm looking at. This is why your dog has a cruciate tear. And so anyway, the distance between the green line and the yellow line is actually the amount of cranial drawer. So let's say you calibrated this x-ray and made it life size. If that was 6 millimeters between those lines, that's how much cranial drawer you're actually getting. So it's very nice to be able to actually draw these lines and measure it and get a very objective measurement of that. So in this case here, you can see the tibial translation equals the cranial drawer. Now, if I put that knee in extension and did this, the tibia would come back and it would look like there was no cranial drawer. So that's why it's important to position the radiograph properly. So let's just take a look where this is valuable. In the beginning of the lecture, we talked about different type of cruciate tears. We talked about a stable partial tear, a late or unstable partial tear where there actually is more cranial drawer, and a complete tear. So when we stick a scope in the joint, we can see here's a normal dog here, and we can see that the ligament is completely intact. Here's an early partial tear, a late partial tear, and a complete tear. So look what happens to these lines as you get more advanced tearing. Now, the first thing I want to point out is that a normal dog has about 2 millimeters of drawer. Okay, so a normal dog does have cranial drawer, and you can see that the distance between these two lines is very narrow. And that's a normal dog having the tibia sliding 2 millimeters, which is normal function. When we look at this early partial tear where only a few fibers are torn, you can see that the distance between those lines is very similar to a normal dog. It may be 1 or 2 millimeters greater. So a stable partial tear is going to only have 3 to 5 millimeters of drawer, which compares to the normal dog, which has 2 millimeters of drawer. But as this partial tear gets more severe, you can see these lines start to get further apart. So an unstable partial tear may have cranial drawer of 6 to 8 millimeters. And then as you get a complete tear, those lines get even further apart. And this is typically 10 millimeters or greater. So this helps you diagnose what type of tear you have based on your radiograph if you learn to measure the distance between these landmarks. Another subjective way to do this is to draw a line up the back of the fibula and see where it intersects the femoral condyle. Okay, so you're not actually measuring how many millimeters of cranial drawer. This is a subjective test to kind of give you some suggestion of hey, this tibia is not in the right place. It's not sitting under the femoral condyle. It's moved forward. So normally, if you draw a line up the back edge of the fibula, it comes behind the femoral condyles. But as the cruciate starts to tear, the tibia starts to creep cranially. And as it creeps cranially, the fibula goes with it. And now look in this stable partial tear, you can see that now the line is starting to intersect the femoral condyle. As the cranial cruciate becomes less stable, the tibia moves more cranial, and now that line is in about the mid portion of the femoral condyle. And when it completely tears, you can see that the line is at the cranial edge of the condyle. So you can see that just by drawing a quick line up the back of the fibula, it gives you a hint whether there's a cruciate tear and whether it's a partial tear or a complete tear. We already talked about the osteophytes here. Okay, so we're going to skip this slide. Okay, now we're going to talk about treatment. And the important thing to remember is you're doing your client a disservice if you tell them not to fix a cruciate tear. Okay, so again, I would love to teach you how to fix cruciate tears in our hands-on labs. But if you're not going to do it, the best recommendation is to get them to someone who does have experience doing it. So why is that? Well, we already talked about the inflammation and the mechanical stresses on the cruciate and the fact that partial tears will continue to get worse and get arthritis. And here's an example. Here's a dog with an early partial tear, no osteophytes, and you can see very little swelling in the joint. Here is the same dog a few months later, and now you can see that this dog obviously has a complete tear, and you can see that we have osteophytes forming, the tibia is dramatically displaced cranial, and we have swelling in the joint. And this is the dog, again, no treatment, 1 year later. And you can see now this dog has end-stage arthritis, and this dog's going to do very poorly. So this is a predictable course of disease with cruciate tears. Okay, so there's two basic ways to treat a cruciate. One is with an extracapsular suture system, and the other was with an osteotomy technique. There's different types of osteotomy techniques, but the tried and true and the one that's done by far the most is the TPLO. But there's a TTA, there's different types of TPLOs, and there's something called a CBLO as far as the osteotomy techniques. Now, here's the traditional Securos clamp technique. And then there's various other types of bone anchor techniques that are available too. Now, the problem with extracapsular suture techniques, I don't do very many of them. In fact, I do very few of them, even in tiny dogs, is that most of them will stretch out to some degree. Here's a dog here 2 months after doing heavy monofilament leader line. And you can see this dog has got swelling, is having lameness again. And you can see when we went into surgery, the dog has a lot of cranial draw again. The suture has stretched out. Okay, so again, it's providing nothing for this dog. So the big question is why did this fail? What if you look here, you can see a little hole here, and you can see a little measurement here. You can see a line. This is the line of the top of the tibia. So why did this fail? Well, there's a couple reasons why this failed. If we look at that hole and we imagine that suture going around the fibula, and look at that fibula there, that fibula actually looks a little different too. It looks like that fibula has actually done this, okay? So this is the course of that ligament as it goes around the fibula towards that hole. So the main problem with this repair is that it's not isometric, okay? The other problem is that we have a very steep tibial plateau angle. That measures 34 degrees. And so there's a way to learn how to do that. And in our you can read about it, or in our courses, we teach you how to measure this, but it takes a little bit of time to go through, and we have time limitations in this lecture. But you want to learn how to measure that tibial plateau angle, because we know that can be a problem. And I'll show you a chart in just a second. The other thing is if you go around that fibula, it can tear that ligament that attaches the fibula to the femur. And if it tears that, the suture pulls through and loosens. So if you're going to do an extracapsular repair, it's probably best to use a technique that anchors into the bone rather than going around the fibula. Okay, so we're going to go ahead and try to move past. So what's important is to put that suture in an isometric position. So all this means is the distance between the femoral condyle and where you attach the ligament on the tibia stays the same no matter if you flex or extend the joint. If you'll recall in that last case, the ligament was the suture was attached way down here where my arrow is on that middle image. Okay, so if you attach it way down here, what happens is that's not isometric. So when you flex the joint like this, that distance, if you can imagine this dot being way down here, you can see that that's much longer. So if you tighten the ligament in this position, but you flex the knee, it's going to stretch the ligament so that knee can get into flexion. So if it's not isometric, you're going to have a problem. There's going to be excessive stress on your repair ligament, and it's going to stretch out like we saw in this case here. So where is the isometric position? Well, it's just below the level of the fibula, okay? This F2 site is ideal, and this would be using a bone anchor in that position. The F1 site is also acceptable up here. So these are two femoral sites that you can use. I usually prefer the F2 site. It's a little bit better than the F1 site. Now the tibial sites, the best site is T3, okay? But if this again is a little bit more difficult to do. So if you're having trouble using that site, this T2 site is also acceptable. Now, the tibial site that was used in that failed case was way down here again. So the bottom line is you want to make sure your tibial attachment site is up near the joint surface on either side of that long digital extensor tendon. So if you put it down here very low on the tibial tuberosity, almost all those cases will stretch out with time because it's not an isometric position. So that is your ideal site for your replacement of your cruciate ligament. And this actually will mimic the original ligament's position. So the native ligament runs at this angle too, inside the middle of the knee joint. Now, if you're doing extracapsular suture, take a look at this case over here. This dog has a 34-degree tibial plateau angle. Look how unstable this is. The femoral condyle is falling off the back of the tibia. So it's hard to imagine that putting a piece of fishing line across there is going to hold that long term. So we know when this tibial plateau angle, again, this one here is 34 degrees, anytime it's over 30 degrees, we can see that the force on the ligament skyrockets or it becomes geometrical. So if you have a slope over 30 degrees, I'd strongly recommend against an extracapsular suture repair. It's got a much greater chance of failing, and this dog here is an example of that. Now, even if it's less than 30 degrees, you can still do an osteotomy technique, but we do know that the chances of the extracapsular technique goes way up after 30 degrees based on this study done by Don Hulse in 2009. So greater stress on the extracapsular ligament occurs in this shadowed area here. So this is just an example of a case. Now this dog does not have an excessive slope, okay? So this is less than 30 degrees. And you can see that this has been repaired with an extracapsular technique using a bone anchor. But 8 weeks post-operatively, you can see that the tibia is starting to move forward. So we measured the angle, the displacement, like I showed you earlier, and 8 weeks later, this suture material is starting to stretch out. And this is actually very common. So this is why I typically will do TPLO even in small dogs, but I recognize the fact that many dogs can still do well with extracapsular. And we teach people how to do these, making sure they hit their isometric points, because that's going to decrease the amount of this instability that is formed. Now the TPLO, how does that work? Well, again, remember, when a dog takes a step, there's a weight-bearing force that comes up the tibia and crosses the joint. As you push this slope surface against the round surface, because of this force, you're basically taking that slope tibial plateau and pushing against the round surface. As you do that, it wants to slide forward, as shown here. This is that cranial tibial thrust force. So when we do a TPLO, we're going to make a cut in the tibial plateau here, and we're going to take the surface of the joint and we're going to rotate it caudally. So the plateau is going to start here, and as we rotate it caudally, it becomes level. So you can see on this diagram over here, the tibial plateau is now level because we've taken this proximal tibial segment and we just turned it. And we turn it to its level, and then we lock it in place with a plate. So now, when that dog takes a step, here's that weight-bearing force again. Now the plateau is level, and as you push up, it doesn't slide. So recall in the before surgery where it was angled, as you push up, it slides. But now if you level it and you push up, it just stays there. So the TPLO works by eliminating this cranial tibial thrust. Okay, so again, when you do this and flatten the plateau, by eliminating this cranial tibial thrust, you're taking the force off of this cranial cruciate ligament. So before surgery, this thrust here is being counteracted by the cranial cruciate ligament. And this is one of the reasons why it tears. This ligament has to counteract this force every time the dog takes a step. So now, once you do a TPLO, you eliminate that force. So now the cruciate ligament doesn't have to work as hard. So the TPLO will actually save partial tears. So if we do a TPLO very early during the course of a partial tear, it takes the stress off it and it will save it. And I'm going to show you that right here. Okay, so here's a dog. You can see we've done our measurements, and this is the cranial drawer. The knee's at 90 degrees. So you can see the tibia shifting forward. Once we do the TPLO, when we make our circular cut and we level that plateau, look at our lines now. So because we've leveled the plateau, the tibia is no longer shifting forward. So this dog is still anesthetized. So we get stability immediately once we eliminate that cranial tibial thrust. Okay. So I want to show you a case here. Here's an early partial tear. So if you look at the image on the left, here's the intact part of the ligament, and you can see the torn parts. So we went in surgically with a scope, and we cut out or eliminated these torn portions. And you can see after we've eliminated all the torn ligament, this is the remaining ligament that's intact. So here's the remaining cranial cruciate ligament. Here's the caudal cruciate ligament. At this point, we did a TPLO. So what is that TPLO going to do? When we level the plateau, it takes the stress off these remaining fibers. Okay. Now, this dog tore his opposite cruciate 1.5 years later. And when we were fixing that one, we asked the owner if we could stick the scope in the original knee and see what the cruciate looked like. And you can see that this ligament here looks like this 1 year later. Looks very, very healthy and intact. So by taking the stress off of this partial tear with the TPLO, we've removed those stresses off the ligament, and it's saved our cruciate. Okay. So when we do a TPLO, this is how it looks. So you can see a little stab incision here. We stick a scope in the joint to take care of the ligament, and take care of any meniscal tears. And then we just make a little incision over the medial side of the tibia, just through the skin, to make the cut in the tibia, to rotate it and put the plate on. So this is the dog next day. You can see that they typically are going to use the leg next day. This is another dog next day, 1 day post-op. So by doing TPLO minimally invasively, we're able to get them to recover very, very quickly. The last thing I want to leave you with is the importance of early diagnosis and treating this before you get a lot of OA. These 3 dogs are 1 year post-TPLO. When we did their surgery, they had mild OA, okay? So you can see at 1 year, around pretty well. 1 year post-op, even with mild OA, these dogs are all doing very well. So doing the TPLO with mild OA can give a very good result. Excellent result long-term. These 3 dogs, same problem. All these dogs I'm showing you right here had complete cruciate tears. The difference between these 3 dogs is they also had severe OA at the time of the TPLO.
Well, this is better than an amputation.
Go, Nevada, go, you can do it.
He was scheduled for...
So you can see in those dogs, they're just not walking as well. And it's not because of the cruciate, the knee's stable. It's because the owners did not recognize the condition early enough, and we didn't intervene early enough before severe OA was already present, okay? Lastly, whenever you're doing cruciates, always look at the meniscus. When the cruciate tears, you can see that there's a lot of pressure on the back of the meniscus as the knee goes through cranial drawer, and it causes this meniscus to fold up like this and tear. So that's why we see bucket handle tears in this region here. So you need to look at the meniscus, and you can use a Homan retractor as shown here, hooking on the back of the plateau to bring this meniscus. Here's the tear way back in the caudal aspect of the joint, okay? Another thing you can get, I usually like this instead of the Homan. It's called the Ventura Stifle Thrust Lever. You can get it from IMEX. It's just smaller so you can see past it easier. And it's got a little hook in it like here, which gives you a great ability to see the meniscus. And you can see these little tears here. So here's a little tear here that you can't really see. So we probe it and you can see this caudal bucket handle tear of the meniscus, so that we can cut here and remove this torn meniscus. So this is an example of a partial meniscectomy where we've removed that bucket handle tear and we've left the remaining meniscus in place to cushion the joint. Okay, so when we watch this little thing here, here's a probe. You should get one of these. You want to probe that meniscus and you can see the tear here. So to do a partial meniscectomy, all you're going to do is you're going to come cut this cranial bucket handle here. Uh-oh. Okay, try it again. Sorry about that. So you're going to probe the meniscus with a probe. You're going to come in here and you're going to cut the cranial part of that tear here. This is using an arthroscopic instrument. You can use a scalpel blade if you want to. Then you're going to have to cut the caudal arm too. And so you can go in and you can grab it with a hemostat or a grasper as shown here. You're going to grab it and just put a little traction on it. And then you're going to go in with your instrument and cut the back part or the caudal horn. And then you're going to remove it. And then you're done. You don't have to do anything else. We do this through that little stab incision arthroscopically, but you do the exact same thing. But when you do it arthroscopically, this is probing to show the tear. So a lot of these tears are not forward. You have to pull them forward. And now we're going in and we're just doing the exact same thing. We're cutting the cranial arm first. Okay. And now we're going to cut the caudal arm here. And then we're done. So again, don't take out the whole meniscus. The remaining part of this meniscus is going to cushion the joint and prevent OA. Lastly, we know that all dogs get arthritis despite the repair. We need to understand that this prolonged joint inflammation is very important, okay? When we do a cruciate repair, if we look in that joint a year later, you're going to see inflammation in the joint. So there is low-grade inflammation long-term. And that's why if you read all these journal articles after cruciate repair, all dogs will get some degree of OA. The reason why they're getting OA is this prolonged silent synovitis. So if we look in this joint here, here are 50 dogs that we stuck a scope in a year or more later into their knee after stabilizing the knee. 100% of these dogs had synovitis. These dogs are running, jumping, and playing. But the reason why they get OA is not because the knee's unstable. It's because the biology in the joint never goes back to normal. There's low-grade synovitis, and this is the cause over the months and years later that these dogs come down with OA. So after you do cruciate surgery, your job's not over. You need to put them on some sort of anti-inflammatory to prevent this persistent synovitis. And what this synovitis causes is loss of proteoglycans in the cartilage. And eventually, with increased stresses, it leads to OA. So our job is to decrease this synovitis using some sort of anti-inflammatory to get the proteoglycans back in the cartilage. So one of my favorite ways to do that is not to use the stronger anti-inflammatories because they have a higher risk profile. So we can use things such as the fatty acid supplements, which are anti-inflammatory, but have a low risk profile on a daily basis. So you can use the fish oils. There's a lot of different fatty acid supplements that you can use for this chronic inhibition of the inflammation. Now, my favorite one is a product called Antinol, and I've used this for about 7 or 8 years now. And this is made by a company called Vets Pets. Again, I used to use a lot of fish oil. You can use this with fish oil, but this has been shown to be more effective in lowering inflammation in these joints. So this is a product that comes from the New Zealand green lip mussel, and it's a fatty acid product, but it's very different from fish oil. And it actually has over 90 different fatty acids and lipid compounds. Probably the effectiveness and why this is superior is how it's extracted. It makes it a stable oil versus an unstable oil. The other nice thing about it is it can be used in dogs and cats, and it has very good safety data in both dogs and cats to show that it's safe for liver, kidney, and GI. And there's also good outcome data. So this is just one study that was done in dogs. It's a prospective blinded study, and these are dogs that had hip or knee arthritis. And they looked at Antinol, which is also called PCSO524. It's a very specific green lip mussel product. There are other green lip mussel products out there, but you want to see this PCSO524 on the container to know you're getting the right stuff. It was compared against chondroitin sulfate and chondroitin sulfate type product, as well as carprofen. And also, it was looked at in combination, the Antinol with a carprofen product. So you can see when we looked at this using a force plate, that very quickly the Antinol product shows within 2 weeks shows an improvement in force plate scores, and very similar to carprofen actually. And the take-home message here is the Antinol did much better than the chondroitin product. And the other take-home is that if you combine the Antinol with carprofen, you get a synergistic effect. So you can use these products together as well. So one strategy oftentimes is to use carprofen along with that Antinol and then withdraw the carprofen because of the safety risks for long-term use. So many of these dogs after cruciate repair we'll keep them on the fatty acid product, the Antinol, for a lifetime daily. And then if they have episodes of lameness that occur intermittently, we'll add on an anti-inflammatory such as carprofen or another anti-inflammatory for a few days. By using this, we get the long-term inhibition of that synovitis that we know is in the joint, causing that long-term arthritis. And then if they have occasional lameness that breaks through, we'll put them on the NSAID. This was a study that looked at carprofen. There was a similar study, and I was actually involved in this study, where instead of looking at carprofen, we looked at furocoxib, but we got the same sort of findings. We saw that the Antinol showed a very quick result and showed prolonged anti-inflammatory activity by peak vertical force improvement. And we saw that with the Previcox as well, but because of the increased safety factor with Antinol for a long-term daily type product, we felt like that might be a safer way to go. Now you can again use these two products together. And when you use them together, we saw again, like the carprofen, a synergistic effect. So if you've got that really tough case, then using these two products together is probably a good strategy. And again, this is just some data that supports that. And again, we see that this is a different type. The last studies looked at force plate. This is an owner survey, and it showed that the Antinol was seen very favorably. And these were blinded studies by the owners as well as the force plate data. Lastly, this is just comparing it to fish oil. And we can see that when comparing it to fish oil, we saw the blue is the Antinol, the red is the fish oil. You want a lower score to show improvement. And you can see that the lowest scores by about a factor of 2 is seen with the Antinol versus the fish oil. So this is a product that comes from the green lip mussel in New Zealand, but it definitely is very different from fish oil. And again, that's why I will use this product in comparison to fish oil. Now, some people, if they're already on fish oil and they want to stay on it, there's no problem letting them be on both. There's no data to show what happens when you're on both. But again, anecdotally, I haven't seen a problem using the Antinol along with fish oil if the owners want to do that. So again, I'm going to go ahead and stop there. In summary, early diagnosis and treatment is essential to optimal outcome with cranial cruciate ligament injury. TPLO is very, very ideal, especially with partial tears, because it takes the stress off that ligament, saving the cranial cruciate ligament, and this helps lower the risk of osteoarthritis in the future, as well as future meniscal tears. So if you can save the native ligament, you're going to reduce your chance of problems down the line. Remember, after any type of cruciate surgery, synovitis is going to be around long term. We found that with second look arthroscopy studies, looking in the joint 2 years, 3 years, and even further down the line. So even though the dog clinically seems to be doing good, that synovitis is causing OA, and it's eventually going to take a toll, like has been seen in the long-term outcome studies following cruciate repair. So manage this synovitis on a daily basis using some sort of anti-inflammatory. You can use the traditional anti-inflammatory drugs if you like, but they have a higher risk profile. So I would consider these fatty acid products, such as Antinol, to manage it on a daily basis. And then if clinical signs worsen, use the traditional nonsteroidals on a short pulse type of therapy. Thank you very much. I know this took a little bit over an hour, but there was a lot of information to get to you. I wanted to give you some practical tips for diagnosis, surgery, decision-making, as well as treating this patient long-term after surgery. Again, if you'd like any of these slides, just shoot me an email at this address. It's brianbeale@me.com. Happy to share them with you. And perhaps they'd come in useful when you're talking to your client.